Welcome back to Health of Today's Woman. We are very lucky today to be joined by two well-known breast surgeons from the Murfreesboro Medical Clinic, Dr. Rebecca Baskin and Dr. Jimmy Carter. We've been discussing breast disease. In our last segment, you will notice that Dr. Baskin talked a lot about the mammogram, what was involved. We also talked about MRI. And one of the things that I want to focus on now, we talked a little bit about something called a stereotactic biopsy. So I want to talk a little bit about biopsy and the information we get from it and who needs it. So Rebecca, that's my question to you, is who actually needs a biopsy?
Well, we talked about basically anyone that notices anything new needs further workup. And if something is new to touch that is concerning, shows up new on mammograms, such as we showed the mass or calcifications, or something that's solid or causes distortion on ultrasound or suspicious on MRI, all of those are then going to be biopsied. The good thing is that nowadays we're able to do those with minimally invasive techniques, and that means with a little bit of medicine to take down anxiety, lots of numbing medicine done very slowly and very gently, and a very tiny incision, and can very quickly, sometimes the same day, get you a biopsy result back to allay those fears. Because as we mentioned, greater than 80% of the time that's going to come back something benign, and then that patient will never have to go to the OR or the operating room and have an anesthetic and have a large incision on her breast to get that answer.
Well, it's amazing the extent that we've gotten to in breast disease to be able to control these things and no longer have to do open biopsies. Jimmy, what about the patients you mentioned a little bit about minimally invasive. Is there anybody who needs to go for an open biopsy in the operating room anymore?
When I started practice almost 20 years ago, most of our biopsies were done open. Today and throughout the course of the last 10 to 15 years, we've been able to detect images of things inside the breast with ultrasound, with mammography, and with MRI. So if we can see some kind of lump or mass or calcium deposits within a breast with some kind of imaging guidance, ultrasound, mammogram, or MRI, we can get to that area of the breast that's of concern and take a biopsy with a needle. We have several different high-tech needle devices to get to these lesions. However, if a woman presents with a mass in her breast that doesn't show up on any imaging study like mammogram, ultrasound, or MRI, then we are left with the old gold standard of surgical open biopsy. There was a report recently in the lay press that 80% of biopsies in the country are still done with the open technique. In our practice, and I think the practice around Metro Nashville, most practices are done, breast biopsies are done through the skin with a tiny nick with a high-tech needle and some kind of image guidance.
That's amazing, and that's something that's really important to communicate to patients, I think, is this whole idea that you don't have to go to the operating room anymore, and it doesn't need to be a scary experience. Now, one of the questions I do want to move this to is when they get this biopsy back, you know, if it's benign or non-cancerous, where does the patient go from there?
Well, certainly a biopsy, much like the way we get to breast masses today, is very high-tech. It's based on image guidance and very high-tech needles. The pathology report is also complex, and I think there may be an idea out in the community that, well, it's either good or it's bad, either it's cancer or it's not. The problem is we now know, over the course of many years of research, that certain benign biopsies or biopsies that are not cancer have certain little changes or little nuances under the microscope when they're looked at that suggest that this particular patient may be at an increased risk in their lifetime for developing breast cancer.
And so one of the most important things I think I hear you say is that you communicate with your doctor about what they did find and not just take that it's just a benign or a cancer, but you understand what they said was benign. And even, you know, as I tell my patients oftentimes, write it down so that in the future when you're meeting somebody else, you can communicate this is actually what they found.
Because people do move and change physicians, and you want to know truly what your diagnosis is, so that your physician may change your screening practices based on if that biopsy said that you're a little bit higher risk than your peers, or if you're at the same risk as your peers. And you want to be educated on that yourself.
Well, we are very lucky to have had Dr. Baskin and Dr. Carter with us today. This is a great topic. It is one that lays a lot of fears in women about breast cancer, and that is a scary experience. In our next episode, we're going to deal with a different topic. We're going to deal with the topic that women of age will eventually run into, and that is menopause. We will be joined by Dr. David McKnight, a GYN at the Murfreesboro Medical Clinic, and Dr. Cindy Smith, a pharmacist at Reeves Sane Compounding Pharmacy in Murfreesboro, Tennessee, to understand bioidentical hormones, symptoms of menopause, and some of the parts of menopause that are important. Please realize that for diagnosis or treatment, you need to see your own physician.